Happy Friday, everyone. Welcome to today's webinar, Chest Pain Evaluation and Management, Putting the Guidelines into Practice. My name is Natalie Navarre. I am the Senior Program Development Manager for Get With The Guidelines CAD. Before we get started, I'd like to go over a few housekeeping items. This webinar is being recorded and will be sent out via email within 24 hours. There are no CEs associated with the webinar, but you may access a certificate of completion in your follow-up email after the event. You will have the opportunity to submit questions by typing them into the questions pane of the control panel. If you experience any technical issues during the presentation, most can be resolved by refreshing your browser. If your issue is not resolved following a refresh, please refer to the GoToWebinar customer service team, whose contact information can be found in the webinar confirmation email. The AHA's 5 inpatient Get With The Guidelines programs promote adherence to the latest research-driven guidelines and provide data capabilities to drive continual and continuous process improvement in patient care. The QR code on the screen at the bottom right will allow you to request further information on these programs if you would like. Next slide. We all know that timely, quality chest pain evaluation is key to risk reduction for all sites, and that chest pain incidence is remarkably high. Get With The Guidelines CAD entry criteria updates were made in February of 2023 to add chest pain as a new patient category that sites can capture and Get With The Guidelines CAD, in addition to our STEMI and NSTEMI. In response to customer feedback, these updated entry criteria and the comprehensive 2021 guidelines for the evaluation and diagnosis of chest pain, the AHA and our clinician volunteers developed a set of reporting measures for the chest pain population. These were added to the tool just this month. They are listed on the slide you see here. And again, for more information on Get With The Guidelines, please visit our website or utilize the QR code on the screen. Next slide. Our presenter today is Dr. Abhi Goyal. Dr. Goyal is a cardiologist and epidemiologist who serves as an associate professor of medicine in the Division of Cardiology at the Emory School of Medicine, with a joint appointment as assistant professor of epidemiology at Emory-Rollins School of Public Health. Dr. Goyal's broad research interest involves population research, investigating the link between dysglycemia and cardiovascular disease. His specific research interests include investigating hyperglycemia and as a prognostic marker and a therapeutic target in patients with ACS, and also reducing cardiovascular risk in populations with diabetes. Dr. Goyal practices inpatient general and nuclear cardiology at Emory University. He is also the chair of our Get With The Guidelines CAD Systems of Care Advisory Group. Next slide. Our moderator today is Dr. Steve Sigal. Dr. Sigal is the Director of Interventional Cardiology at Heart and Vascular Center at Titus Regional Medical Center. Dr. Sigal trained in internal medicine, cardiology, and interventional cardiology at Yale University. He moved to Mount Pleasant, Texas in 1991 and practiced in East Texas before founding the Sigal Heart Center in 2002. In 2016, he joined the Heart and Vascular Center at Titus, where he practices general and interventional cardiology. He has strong interests in the early detection of disease, preventative care, and lifestyle management. He is an active member of our Get With The Guidelines CAD Systems of Care Advisory Group as well. And now, Dr. Goyal, I will pass it on to you for our presentation. Thank you.
Great, thank you, Natalie. Can you hear me okay?
We hear you great.
Okay, terrific. All right, thank you everyone for joining this webinar. It's a real pleasure and privilege to be presenting and to be joined by Dr. Sigal, who's been a great colleague on the committee. I also serve, along with Dr. Sigal, I too serve on the Get With The Guidelines CAD advisory group as the chair, and so we're charged with bringing you this content to make it useful to our attendees in terms of how to implement knowledge on clinical decision pathways for the evaluation of chest pain and the use of high sensitivity cardiac troponin testing. Neither of us have any disclosures. So this is our guideline for the talk. We'll first go over the recent 2021 ACC-AHA chest pain guidelines, and then go into high sensitivity versus standard troponin. We'll then go into myocardial injury versus infarction, the clinical use of HS troponin, and look at some data regarding whether HS troponin improves outcomes, including ED throughput, resource utilization, and major adverse cardiac events. And then finally, we'll show an example from Emory Healthcare about how the protocols are used before we go into a moderated question and answer session with Dr. Sigal. These are the 2021 AHA-ACC chest pain guidelines that were published in 2021. We'll be referring to these on the following slides. It was the first time that these organizations came together to produce a clinical practice guideline specifically on chest pain. And one of the nice pictorials in this particular guideline is they have taken the word chest pains and they have created a 10-point summary starting with each of the letters. And briefly, chest pain refers to more than just pain in the chest. It encompasses all potential ischemic symptoms that patients can experience. H stands for high sensitivity troponins, which are now considered the standard of care, no longer standard troponins. Early care for patients with acute chest pain, particularly in order to rule out STEMI, for which emergency reperfusion therapy is indicated. Share, S is for share the decision making. T is for testing, where testing is not routinely needed in low-risk patients. P is pathways in terms of the use of clinical decision pathways. A is accompanying, where what are the accompanying symptoms and what are the types of populations where the chest pain symptoms may not present in a classic format. I is identify as part of risk stratification who might benefit from further testing. N indicates a change in terminology. The terms typical and atypical are no longer favored. Instead, cardiac, possibly cardiac, and non-cardiac are preferred. And then S is having a structure or standard in terms of how risk assessment should be used. These are 10 points. When I teach trainees at Emory, I essentially try to boil this down to 4 key takeaways. First, the classic ischemic symptoms of chest pressure or heaviness, like an elephant sitting on the chest radiating to the left arm of the jaw, doesn't happen in a significant minority of patients. And there are 3 particular patients which have non-classic chest pain presentations, and that includes women, the elderly, and patients with diabetes. I do emphasize that now high sensitivity troponin is the standard of care, which is why it is a substantive portion of our talk today. It is critical to use a clinical decision pathway to stratify chest pain patients into low, intermediate, and high risk. And the job of ED clinicians, ED physicians, cardiologists, other healthcare workers is to not just rule out MI or rule in MI, it's also to rule out other lethal causes of chest pain, including dissection of the aorta, pulmonary embolism, pericarditis with tamponade, pneumothorax, and viscous rupture. Now we'll shift over to high sensitivity versus standard troponin. This is a template for those centers that have not yet made the shift from standard troponin to high sensitivity troponin. I've put side by side at Emory Healthcare what our standard troponin assay used to look like before we went live with troponin in 2021 with the HS troponin assay. And the units are reported as nanograms per ml. When you report as HS troponin, it's reported as nanogram per liter, and therefore the values are multiplied by 1,000. It's also customary when you're talking about high standard or high sensitivity troponin that we report these values as integers, as whole numbers, without decimal points. The recommendation of many manufacturers of these assays is to have separate cut points for women and for men. This is because the LV mass in women tends to be on average slightly less than that in men. And we do not want to under-detect myocardial injury or myocardial infarction in women and men. And so at Emory, we have honored that particular recommendation from the manufacturer, and we have separate cut points in women and men. And for our assay, that cut point is 15 in women and 20 in men. We'll get more about the assays in just a moment. But anything that is above the 99th percentile is considered abnormal, which is again 15 for women, 20 for men. We'll get to myocardial injury versus infarction now. There's a little bit of some background noise. I don't know if we have the capability, Natalie, of muting our participants on our end.
Yes, I'm looking into that right now. I'm not sure what's going on.
What I'm telling you is I have never seen a single key over there. I don't touch.
If we could kindly ask all of our attendees to mute.
Because I have. I never touch your lift gate, and the last time I touched it was the.
Sorry, Abhi, we are trying to figure this out.
Yeah, next time you need someone with IT who can troubleshoot on the fly. Let me know when we're ready.
It sounds like we're good now.
Are we good?
I believe so.
Okay, can you hear me?
That's fine.
All right, so now we'll go into the difference between myocardial injury versus myocardial infarction. And these, and before we do that, let's talk about the imperative for why this is such an important topic. What we've learned in our experience is many clinicians have the reflex that whenever troponin is elevated, they will automatically label the patient as having an NSTEMI, which really triggers them to go down the type 1 MI treatment pathway, which is MI due to acute plaque rupture or acute thrombosis. They'll start heparin, dual antiplatelet therapy, maybe early invasive approach. And for those who are not having a type 1 MI, it can cause potential harm. Troponin elevation, as we'll see, really only indicates that there is injury to the myocardium. It does not tell you what the mechanism of that injury is, as we'll go over in quite a bit of detail. In January of 2017, Medicare introduced the AMI episode payment models, which really makes it imperative to make sure you're properly diagnosing MI as opposed to other types of myocardial injury. In October of 2017, a distinct ICD-10 code for type 2 MI was introduced. And this occurred about 10 years after type 2 MI was formally introduced in the 2007 Universal Definition of MI document, which is a long time to translate a recommendation from a major guideline into practice. The fourth Universal Definition of MI came out in August 2018, which clearly distinguished MI from non-ischemic myocardial injury. And it also discussed NSTEMI and STEMI really as types of type 1 MI, and type 2 MI, we should avoid using the terminology NSTEMI and STEMI when we're talking about final diagnoses. Type 2 MI is coded also now as a major comorbidity and complication by CMS, which has payment implications. And then in October of 2021, there is a unique ICD-10 code for non-ischemic myocardial injury as well. And so it really behooves us from both a clinical practice and a coding and documentation and payment standpoint to be able to distinguish type 1 MI, type 2 MI, and non-ischemic myocardial injury. So according to the fourth universal definition of MI, myocardial injury is a very broad umbrella where a patient has a troponin value above the 99th percentile. And injury is considered acute if there's a rise and or fall of troponin values, as opposed to chronic, where it's an indolent chronic, where there's no real rise or fall, it's just chronically elevated. A myocardial infarction specifically indicates that there's injury and there is also clinical evidence of acute myocardial ischemia. It's not sufficient to just have elevated troponin or a rise and fall in troponin. One must also document and note the presence of acute ischemia clinically based on symptoms, ECG, potentially stress testing, and other features. These are pictorials of the different type of MI. Type 1 in STEMI is your classic plaque rupture MI with erosion or occlusive thrombus that is transient. If it were a STEMI, that is also acute coronary syndrome, that's where you have an acute 100% occlusion that is not transient or stuttering, and you could also have a non-occlusive thrombus with erosion that goes distally downstream. Type 2 myocardial infarction, in contrast, is where you have not an acute plaque rupture, but you have other reasons for reduced supply in the coronary arteries, maybe fixed obstructive coronary disease, acute vasospasm, coronary artery dissection, or you have a drop in supply due to hypotension, arrhythmias, tachy or bradyarrhythmias, where you hypoperfuse the ventricle, or a combination of the two. This is properly documented as a type 2 MI secondary to one or more of these underlying causes and should not be called an NSTEMI. Myocardial injury without infarction is due to a whole host of conditions, some of them cardiac and some of them systemic. And this occurs when there is no evidence. There is clear evidence of troponin being elevated in a rise or fall in acute injury, but there is not evidence of acute ischemia, and often your workup reveals other causes. So most patients coming in with a heart failure exacerbation, it is not correct to call them type 2 MI or even demand ischemia due to. It should be called heart failure causing non-ischemic myocardial injury. Myocarditis, Takotsubo or stress-induced cardiomyopathy, defibrillator shocks, all of these can cause acute myocardial injury without infarction. So these should not be called type 2 MI, these should not be called NSTEMI, they should not be called demand ischemia because these are not ischemic in their mechanism. Systemic causes include chronic kidney disease or end-stage kidney disease, sepsis, pulmonary embolism, and other causes that are listed here. Dr. Januzzi, James Januzzi, has published a nice paper in JACC about implementing high sensitivity troponin. This is one picture from his article where it shows levels of troponin and the 99th percentile for his particular assay at his hospital. And it shows you as you go higher up that when you're lower levels of troponin, your differential diagnosis for elevated troponin is quite broad. When you start to get higher and higher levels of troponin, particularly in the 10,000 nanogram per liter range, which translates to 10 nanogram per deciliter in the standard troponin range, that's when you get to very large MI or myocarditis. So the higher the troponin is, the more likely you are to have an actual plaque rupture MI or a profound type 2 myocardial infarction. I do want to point out, though, that even at levels of 1,000, the differential is still pretty broad, including myocarditis, stress cardiomyopathy, PE, and critical illness. At Emory, I'll be showing this slide at the end and also show you how you can access it at the end. We have this pictorial that we've produced. It's publicly available as well, and we have this as a rubric for clinicians who manage patients on the wards and in the ED. Myocardial injury is for any patient that has a troponin above the 99th percentile. If there is clinical evidence of overt myocardial ischemia, including symptoms, new ischemic ECG changes, new or abnormality on imaging, or angiogram showing a culprit lesion, it's called an acute MI. And then you have to determine whether it's properly determined as a type 1 and STEMI, where it could be acute plaque rupture, in which case cardiology consultation, urgent cath, treating per guidelines is recommended, or if it could be a type 2 MI secondary to one of these underlying causes. And in that particular instance, the management is really to manage the underlying cause. There is no accepted management at this stage of the type 2 MI per se, other than managing the underlying cause. And if a patient has fixed obstructive coronary disease, to also manage the patient for underlying chronic coronary artery disease with secondary prevention therapies or chronic coronary disease therapies. If the patient does not have evidence of ischemia, it's not an acute MI, and we call that non-ischemic myocardial injury secondary to an underlying cause. The proper documentation is acute non-ischemic myocardial injury secondary to one of these underlying causes, or chronic non-ischemic myocardial injury due to one of these causes. It is also really critical to note that serial troponin values with HS troponin are critical. One of the unique advantages of high sensitivity troponin compared with standard troponin is the values are much more precise when you measure them in succession. And changes mean a lot more. So single values are helpful, but they're of limited value in diagnosis. The serial values to document acute rise and the degree of rise is really critical. And as a clinical rule of thumb, we often say that an ongoing doubling of the high sensitivity troponin raises the concern for type 1 MI and some type 2 MI etiologies like SCAD, embolic infarct, severe vasospasm, etc. Let's now shift over to the clinical use of high sensitivity troponin. And for this, I'm going to heavily refer to the 2020 European Society of Cardiology guidelines for the management of acute coronary syndrome in patients presenting without persistent ST segment elevation. Before I do that, I do want to acknowledge that since then, the European Society of Cardiology has come out with a 2023 document for acute coronary syndrome that combines both STEMI and NSTEMI patients. This 2020 document is for those without persistent ST elevation, and I think in the 2020 guidelines, they actually did a much more comprehensive job laying out the purpose of risk stratifying, and I'm going to draw from some of these for the pictorials, acknowledging that there is a 2023 guideline. In addition, ACC and AHA are actually putting out 2025 acute coronary syndrome guidelines that also synthesize STEMI and NSTEMI patients as well as unstable angina. Look out for that to be published in 2025 as well. And so the European Society of Cardiology recommends having serial troponins as part of a clinical decision pathway where the goal in someone presenting with acute chest pain, particularly to the ED, is to risk stratify them into one of three buckets. Low risk, where we have fairly confidently ruled out acute myocardial infarction. High risk, where that patient has a sufficient likelihood of having an acute MI and should be admitted for further evaluation, or in between those where they're intermediate risk, where that patient may be a candidate for observing perhaps in a chest pain decision unit or a clinical decision unit and maybe undergo stress testing to risk stratify or reclassify into a low or high risk category. The goal for the low risk or the rule out population is, according to studies, this population should have more than a 99% negative predictive value of death or MI at 30 days, not just in that inpatient initial encounter, which means a less than 1% MACE rate at 30 days of death or MI. In contrast, the high percentage group has a 70% positive predictive value for MACE at 30 days, which is why they're observed and potentially treated to avert the MACE from occurring, which may include urgent cath and potentially percutaneous intervention or other revascularization if needed. And so this is a study that demonstrates the benefit of having a 0, 1, and 3 hour, a 0 and 1 hour algorithm, and some extended to 3 hours after the 1 hour. And that's, as I said, where you can take this observed group, reclassify them based on your clinical decision tool, and manage a lot of the patients in the outpatient setting. And it demonstrated with this, what I showed, that the low risk group has a MACE rate at 30 days of less than 1%, which is what we strive to achieve. As we go into this, I want to point out some things related to high sensitivity troponin. Not all assays are the same. So the first step for those of you who are implementing or who have already implemented HS troponin is you must know what assay your laboratory is using. Become familiar with your assay. Know if they are presenting or if you're providing to patients troponin, high sensitivity troponin I or high sensitivity troponin T. And also know what manufacturer and what particular instrument they are using, because the cut points for troponin differ according to these vendors. In an ideal world, you would not have differences in your cut points for 99th percentile and normal or abnormal. The real fact of the matter is all of these assays and how they analyze for troponin are proprietary, and they are slightly different in the molecular biology and biochemistry that detect troponin. And so because of that, their cut points for the 99th percentile differ. So you must know your assay. Also be intentional and know whether you are going to adopt a 0 and 1 hour algorithm or a 0 and 2 hour algorithm. You must be familiar with what are the recommended cut points for low risk and for high risk patients. These are not necessarily your 99th percentile cut points. That is different in the assay. And also know what is considered a significant change in troponin between 0 and 1 hour or 0 and 2 hours. All of these are important features when you're designing a clinical decision algorithm in your patients. Before we get into the algorithm, let's first go over the data, whether HS troponin actually improves outcomes, because there's no point in utilizing this in clinical practice and getting into it unless we demonstrate that there is an actual improvement in outcomes from doing so. At our hospital at Emory, this is early data. We've actually expanded this since then, and updated data are currently being reviewed and I believe have been accepted in our IMPRESS and critical pathways in cardiology. But for now, these are the early data that demonstrate before we implemented high sensitivity troponin, this was the average length of stay in hours in our ED and clinical decision unit. You can see it's measured on the order of 50 hours, 80 hours, and you'll notice almost immediately after implementation, right from that point, these are months of the year, there was about a 40% drop in the length of stay at our different hospitals from implementing HS troponin. So this is encouraging with our own institution that the length of stay is reduced by almost 40%. And particularly ever since COVID, our EDs and our CDUs are just heavily scrutinized for how rapidly they can turn patients over, because the queue for patients waiting for care is really straining our EDs these days. I'll highlight a couple of additional papers coming from experts both in Europe and in the US regarding the downstream consequences. And I want to highlight one particular comment here. Education of your clinical teams really makes a gigantic difference in terms of implementing an algorithm. That was something we spent extensive time on at Emory leading up to our implementation, that we're rolling this out. This is the algorithm. We really rolled it into how you diagnose the different types of MI, non-ischemic injury, et cetera, so that on launch day, it actually went pretty smoothly, and there wasn't a huge commotion regarding what is this and how do we consult people, et cetera. So this is Ganguly's paper published in JACC that looked at 7,500 patients with chest pain at 5 Boston hospitals. And this is changes after implementing HS troponin for patients presenting with acute chest pain. And I'll highlight a couple of things. First of all, anything that is to the right of these hash bars indicates that that resource is being used more often than prior to HS troponin implementation. Anything to the left of this hash bar indicates that that resource is being utilized less often. So not surprisingly, after implementation of HS troponin, what our colleagues found was that troponins were being checked more often, which is not a surprise because HS troponins require the use of serial tests. So that is not surprising. Interestingly, the use of secondary prevention medications was lower because they were able to more confidently rule out patients for chest pain and have a lower suspicion of coronary disease as an underlying diagnosis. And so actually coronary disease-related medications were prescribed less commonly in those patients. Encouraging to many people in the cardiology community, hospital admission and also cardiology consultation occurred less often, not more often. I have a confession to make at Emory. It took us a long time to adopt troponin because we were concerned, HS troponin, because we were concerned it was going to lead to a glut of cardiology consults. And we kicked the can down the road until 2021 when our vendor said, you really won't have a choice because we're retiring the old assay and we're only going to offer HS troponin. So we were encouraged to see data, and our own experience has shown that cardiology consultation has not increased since HS troponin implementation. ECG use has increased. Now this is also not unexpected, because whenever you recheck troponin, it is often good clinical practice to go ahead and repeat an ECG to see if there's evolution of changes. So more troponins and more ECG is not a surprise. But stress testing was reduced. Cardiac CT and CT angiography was also reduced. And there was no change in overall PCI or CABG. And so an increase in troponin tests and ECGs, but reduced number of admissions, consults, stress tests needed, and secondary prevention medications. This is all very encouraging. There are other studies, but I think this is very representative of the data that are out there. What about outcomes? This is the historic trial that was published by Anand and colleagues in Circulation in 2021. This was a step wedge randomized cluster trial of over 31,000 patients presenting to the ED with chest pain, and it looked at a standard care pathway of troponin, looking at a 0, 6, and 12-hour check of troponins, which is what we used to do for old troponin, and a 0 and 3-hour high sensitivity early rule out pathway. And this is what they found in their 31,000 patients. They were able to discharge more patients from the ED with their new high sensitivity troponin early rule out pathway, 20% more. And I believe their length of stay dropped from around 10 hours to 7 hours on average. So it was a median 3-hour reduced length of stay in the clinical decision unit. Their 30-day MACE was not different. At 1 year, there was no statistical difference in terms of p-value at 1 year. Numerically, interestingly, the number of MIs was actually, the rate of MIs was actually lower in the early pathway. And deaths at 1 year also were not different from a statistical significance standpoint, although the deaths were slightly lower in terms of the rate. From this, I think we can conclude that high sensitivity troponin does improve ED throughput. It reduces the length of stay often by 30 to 40%. It does not increase resource utilization. We do not see an increase in cardiology consultations, in admissions, in stress tests, in revascularization procedures. And importantly, the increased efficiency gained by using HS troponin in terms of ED throughput and in reduced resource does not compromise clinical outcomes, which is really a great boon. This is a big win-win in terms of the use of HS troponin in clinical care. We'll finally now, with this background, turn our attention to how we at Emory Healthcare have implemented HS troponin. You will be able to find the tools on our website. These slides will be made available to everybody. I can tell you that if you just Google Emory troponin, okay, the very first link that comes up will be the Department of Medicine cardiology page with all our troponin protocols, and those links will take you right to this data. So the simple thing to do is Google Emory troponin, it'll take you right there. And what we have on here is how we developed our protocol, who were the key clinicians involved in developing it. We had representation from laboratory medicine, cardiology, emergency medicine, hospital medicine, and it was complicated enough to implement this at a 6-hospital system along with Grady that we had to involve a project manager to make sure laboratory medicine, clinical components, and IT were all on track. These are the references we drew from heavily. And before we go into what we did, these were the assays. These are the assays that we currently use. At the Emory hospitals in particular, we use Beckman Coulter, okay, at EUH, Midtown, St. Joseph's, Johns Creek. Emory Healthcare largely uses this one, the Beckman Coulter assays. And we use basically less than 5 as low risk. Delta, the manufacturer recommends less than 4 as a 1-hour delta. High risk change in troponin they recommend is 50, and low risk is under 15 for a delta troponin. And these are the associated sensitivities and negative predictive values of using these cut points, which are in lines with what ESC and the chest pain guidelines from 2021 indicate. I should mention the AHA-ACC 2021 chest pain guidelines also really go into this in extensive detail, but the pictorials are not as well developed as in the ESC guidelines, which is why I'm highlighting those. The last piece of information you need to know before we go into this is the HEART score. This is a risk score that is used for patients presenting with acute chest pain and suspected acute coronary syndrome, not with a final diagnosis of STEMI or NSTEMI that present to the ED. Each letter in HEART stands for one of the 5 major components. H is history, E is ECG, A is age, R is risk factors, and T is troponin. And you can see that each of these is scored 0 or 1 or 2 based on how concerning the history is, how concerning the ECG findings are, the age cut points, whether you have no risk factors 1 or 2, or you have established known coronary artery disease, and what is the degree of elevation of troponin above the 99th percentile. Now I'll spend a couple minutes on this slide. It looks busy, but I'll break it down for you. This is the protocol for acute chest pain that we use in the emergency departments at Emory Healthcare. I want to draw your attention to a couple of things at a high level first. This is not a troponin only algorithm. This is a clinical algorithm that incorporates the symptoms, chest pain, the ECG findings on presentation, your duration of symptoms, whether you have symptoms less than 3 hours or more than 3 hours on presentation, the heart score, which I showed on the prior slide, and that's your pre-test probability for likely having an acute coronary syndrome, single troponin values at 0 hour, and then your on presentation, and then your change in troponin between 0 and 1 hour, 1 and 3 hour, and 0 and 3 hours. So we use all of these things to determine whether a patient is deemed low risk and safe for early outpatient follow-up, high risk where they need to be admitted, or intermediate risk where they need to be in a CDU. I also want to highlight that if your initial ECG shows STEMI, you're done. You don't even go down this algorithm. You don't even care what the troponin shows. If they have chest pain or equivalent symptoms and the ECG meets STEMI criteria, you immediately follow the STEMI protocol where you activate your cath lab for immediate primary PCI, or if you're in a hospital that does not do 24/7 PCI, you immediately deploy and administer fibrinolytic therapy. Also, if you don't meet STEMI criteria, but you have signs of acute ischemia with ST segment depression that are high risk, or hyperacute T waves or other high risk features like Welling T waves, that can put you immediately into the high risk category for consultation, cath, etc., regardless of what the troponin shows. Okay, and so if a patient is low risk, they've had symptoms for more than 3 hours and their heart score is low and their initial troponin is less than 5, which is considered the very low risk value. You don't even need to draw another troponin. You can go straight down here. If their symptoms are very fresh, or their heart score is high, or their troponin is higher than 5, notice that's not the same as the 99th percentile. 5 is very low. That's not just low, that's very low. They can still have a troponin in the reference range of less than 15 in a woman, less than 20 in a man for a particular assay, and not satisfy the criteria for low risk. Then you draw another troponin, and then you go down the node here. Are their heart scores low? Is the delta low? And if so, you're low risk. If not, you continue down this pathway. At any point, if you meet any of these criteria where you have a troponin that's high risk, or deltas that are in between, you'll go down this pathway or this pathway. I do want to point out that we really collaborated very closely with our ED colleagues to come up with this pathway, because they see the vast majority of acute chest pain patients and have to implement this. And so, to their credit, they said, we recognize 50 may be the manufacturer's cut point of what is high risk. We are willing to take that out to 100 as long as the deltas are not very high. And we want to expand the pool of patients that we can admit to a CDU and potentially do stress testing or CT coronary angiography in. That's because we have a very robust Department of Emergency Medicine where a number of our physicians, for example, serve on the chest pain guidelines and on professional societies where they feel comfortable watching some higher risk patients in their CDUs. We also created an algorithm for our inpatients. These are patients who are then admitted. It looks different than the one for the ED. I won't go into this in as much detail. I will say this is also a clinical algorithm like the prior one I showed from the ED, where it asks, does the chest pain sound ischemic? You look at your ECGs, you go down the STEMI pathway if it meets STEMI criteria. If the chest pain is not ischemic and the ECG shows no acute ischemia, you don't even have to order a troponin. You can work up symptoms for other causes. You can also get a stress test on a non-emergent basis. If you have either ischemic or maybe ischemic symptoms and or ECGs that are concerning, that's when you go down a troponin for a 0, 3, and 6 hour pathway, not a 0, 1, and 3 hour, which is harder to implement on a floor than in the ED. And if at any point you have troponins above the 99th percentile, that is consistent with myocardial injury. And then you need to look at the algorithm that I've already shown you, that I'll show again in terms of diagnosing. Is it non-ischemic myocardial injury, a type 2 MI, or NSTEMI? For a moment, I'll go back to this slide. The ED's goal is not to diagnose or give a final diagnosis to the patient. It is to document low risk, intermediate risk, or high risk. Where should the patient go next? And maybe to initiate some treatments. But once you're an inpatient, that's where you really want to hone in on the diagnosis and treat properly. And that brings us back to this algorithm that I've already shown you in a prior slide. That rounds out the education that we provide to our clinicians, that it's not just about knowing your clinical decision pathway. It's not just about knowing the troponin cut points. It's then being able to use your clinical acumen and put them in one of these buckets so you know how to treat them according to NSTEMI guidelines, treating the underlying cause of type 2 MI, or treating the underlying cause if recommended for non-ischemic myocardial injury. So the final conclusions before we get into one case and Q&A. Women and men have different cut points. Know your different cut points for your manufacturer. Some hospitals have opted to not use different cut points and to use an overall population cut point. That is an individual centered decision. Again, at Emory, we opted to use different cut points so we don't underdiagnose MIs in women. Different hospitals have different cut points. Know your vendor and your assay. Know your ED protocol, and the ED purpose protocol is to stratify patients into low, intermediate, or high risk and to start therapies and to get consults as needed. It is not to come up with a final diagnosis, unless that diagnosis they think is a STEMI and they need to activate the lab, the cath lab. The inpatient protocol is slightly different, and that goal is to properly diagnose whether it's non-ischemic injury or the actual type of MI, so you can administer the right final diagnosis and the right final therapy. Myocardial injury does not equal myocardial infarction. As we talked about, this is an umbrella term that includes infarction in patients who are having acute ischemia. And HS troponin is the standard of care. It improves ED throughput, and it does not increase downstream testing, and it does not adversely impact major adverse cardiac events. This is one case example of a patient that actually presented to one of our hospitals, a 46-year-old woman with an early history of CAD who had chest pain burning while watching television associated with nausea and vomiting. I'll note that she was a young woman without diabetes, but because she's a woman, she may not present with your classic symptoms of chest pressure radiating to the jaw or the neck, and she certainly did not. And the ECG was non-specific. Okay, her HS troponin was 24 at presentation, 35 and 31. If you take her through our algorithm here, 46-year-old woman who has a troponin that is between 5 and 100 and continues to have a range there where the delta is under 15 at each time, that puts her square in the intermediate risk group. She went to the clinical decision unit and she underwent at this hospital coronary CT angiogram, which showed a tight lesion in the LAD in the setting of her symptoms that were concerning. A CTA is not diagnostic enough. You need to follow with an invasive coronary angiogram, which actually showed a tight 90% LAD stenosis. And at this point, a diagnosis of type 1 NSTEMI was made. This looks like a culprit lesion on cath for an NSTEMI with the right symptoms and a troponin above the 99th percentile. And a stent was placed, and this is the final result of that lesion where we had a nice angiographic result and her symptoms resolved, and she was put on secondary prevention medications for an MI. So these are the references that I gave throughout the talk. These are very standard references. I've cited them throughout the talk. Again, if you Google Emory troponin, the very first link that'll come up are our troponin protocols. With that, we'll turn it over to Dr. Sigal, who can take us through a moderated question and answer session. And I thank you for your time and attention and interest in the content. Steve, I believe you're muted.
Okay.
I got you,
Thanks,
Steve. I
Abhi,
unmuted you. Thanks.
First of all, I want to thank you for a very comprehensive review, and that's brought a lot of clarity to a very complex topic and complex set of algorithms, particularly for those who aren't involved in this on a day-to-day basis. At the center of your algorithms and at the center of the guidelines is the use of the clinical decision pathway in order to appropriately stratify patients so we know how best to treat them. And I was just wondering, in your institution, you've chosen the heart score. We use that in our institution as well. The guidelines mention as well alternative pathways of using TIMI or GC guidelines as well. So I was just wondering if you could share with us a little bit why your choice of heart score over the other potential decision pathways, and why you think that might be the most appropriate for this setting.
That's a great question. Thank you, Steve. The heart score is a risk score for evaluating patients who present with acute chest pain, which has a broad differential diagnosis. In that differential includes potential acute coronary syndrome, which can end up being a STEMI, an NSTEMI, or unstable angina. The STEMI part is usually very rapidly rolled in or out based on the acute ECG. But these are patients with suspected acute coronary syndrome or who could be having other diagnoses as well. In contrast, the TIMI risk score and the GRACE risk score, which are the other two that are commonly quoted for patients who present, these are for patients who have a final diagnosis of a non-ST elevation acute coronary syndrome. So these are patients with a final diagnosis of a type 1 NSTEMI or unstable angina, which I'll mention is a little bit of a vanishingly small diagnosis, particularly in centers that have implemented high sensitivity troponin, which are so sensitive as to detect even minute increases above the 99th percentile for patients who have myocardial injury or who are having true ischemia. So the reason we have opted, and you have opted, I think, at your center for the heart score is because that is the most appropriate algorithm for patients presenting with acute chest pain, which has a broad differential diagnosis and for which you want to potentially rule in or rule out acute coronary syndrome. The TIMI risk score and the GRACE risk score are used for patients in whom the final diagnosis has already been made for a type 1 NSTEMI or unstable angina. And so it would not be appropriate necessarily to use those in a clinical decision pathway for those presenting with acute chest pain where the diagnosis has not yet been made.
Great, thanks. As you pointed out, you know, the extremely high-risk patients are often easy to pick out. Certainly the STEMIs are going to be identified immediately. And the very low-risk patients are fairly easy to pick out. And in the middle, we have those intermediate risk patients. And some of those will prove to have either non-ischemic myocardial injury, as you pointed out, or type 2 MIs. And the question becomes, once that's been established, of course, we're going to treat their primary underlying illness that caused their troponin elevation. But long-term, as we think about getting these patients back to their normal life again, is there a role for further cardiac testing for coronary insufficiency in these patients? Or can we feel comfortable that in most cases they can go about their normal activity and watch for further symptoms down the road?
Also, a very relevant question that we see all the time in clinical practice, where we are fairly confident based on our workup and what the tests have shown potentially that this patient is maybe not having a plaque rupture MI. Maybe they've been diagnosed with a type 2 MI due to an underlying cause or a non-ischemic injury. But a lot of these patients, as we know, who have a type 2 MI or non-ischemic injury may have underlying fixed coronary disease, and many of them have cardiac risk factors. And because they have had elevated troponin, the question comes up, could they have underlying coronary disease for which preventive medications are needed for chronic coronary disease? And so because of that, after you've ruled out acute coronary syndrome, it is in many cases not unreasonable to do further testing, but it doesn't always have to be done on an acute or even necessarily inpatient basis. I'll give you an example. We commonly have patients who are maybe elderly, who have multiple risk factors. They may have hypertension, diabetes, chronic kidney disease, and they come in with evidence of sepsis, and they may have septic shock. They go to an MICU, they have their septic shock treated, they have a rise and fall in troponin. Maybe they have ECGs that show non-specific changes, but no acute ischemic change per se. They don't have any ischemic symptoms. You know, they came in febrile and maybe feeling short of breath, and they had a huge pneumonia that was diagnosed. And so the clinical team, it would be appropriate in many of those cases for the clinical team to consult cardiology to say, what do you think this is? And maybe cardiology will come back and say, I think this could be a type 2 MI in the setting of septic shock in this hypotensive patient who could have underlying coronary disease because of maybe some AKI and CKD, and we don't think this is acute plaque rupture MI. We're going to say this is unlikely a type 1 NSTEMI. This is most likely a type 2 MI secondary to septic shock. No need to urgently cath the patient. Heparin is not necessarily indicated. Plavix is not necessarily indicated. When the patient is more stable, either before discharge or even on an outpatient basis during follow-up in the coming 1 or 2 weeks after the dust has settled from their acute pneumonia, it's not unreasonable to have them follow up with a primary care provider or a cardiologist and evaluate their risk factors, and that may entail getting a stress test at that time. So it is very appropriate to evaluate these patients for coronary disease, but not always in the acute setting. It's always a risk balance, a risk reward or a risk benefit assessment to determine what is the appropriate setting and when is the appropriate time to do those things.
Right, and I think as the guidelines would point out for even our intermediate risk patients, that sometimes shared decision making with the patient is also important in terms of the timing of that further evaluation.
Absolutely, that is a great point, and that should not be, the value of that should not be understated.
Sure.
Dr. Sigal and Goyal, we are at time. I don't know if you want to try to throw one more very brief question in. I would be all right with that.
No, I think that's fine. Audience at all?
We do have some from the audience. One in particular was fairly specific about if you get a certain troponin value, what should the next? I'm sorry, I'm trying to find it. They get hidden after we flag them. But I think for the most part, it was if the initial high sensitivity troponin comes back as greater than 52. How often do you recommend trending the troponin lab? So I think really looking at the 01, 02, 03 algorithms.
I think if well, the answer to that, of course, is it depends. You know, I put out an extensive sort of clinical decision pathway slide that we use. If a patient has a troponin value that is above the 99th percentile, in our assay, that would be 15 in a woman, 20 in a man. I would just maybe for the sake of example, this patient, say the troponin of 50 was maybe 3 times the upper limit of normal of that assay. It should certainly be followed up with another value at the 1 or 2 hour mark, depending on what your center's algorithm is. And then, based on the delta troponin, the change between the 1 hour and the subsequent value at 2 or 3 hours, you can make a decision in terms of whether that changes your risk of the patient from intermediate risk to high risk, or intermediate risk to staying in the intermediate risk category where you could get a stress test. I will point out that if the value is above the 99th percentile, it immediately excludes them being in the low risk category, so they should not just go home without at least additional serial troponins and observation in the CDU that could warrant a stress test or some other therapy. But you also have to know the clinical context. If a patient is coming in, for example, with known heart failure, with preserved ejection fraction, with LVH, left ventricular hypertrophy, with end-stage kidney disease, who hasn't been on dialysis or missed a couple of sessions a few times, it's not unexpected for a troponin to be high for a variety of reasons, due to reduced renal clearance, chronic elevation from troponin, from the LVH, et cetera. That's very different from a patient coming in with cardiac risk factors who has acute onset chest pain that sounds ischemic with dynamic ECG changes. So the clinical context needs to be factored in addition to a serial troponin value. But in that particular example, yes, I certainly would follow up with another troponin.
Great, thank you so much. Well, I believe we need to cut it off for here. Dr. Goyal, thank you for such a remarkable presentation. For the audience, the slides are in the handout section of GoToWebinar, so you will be able to refer back to them, especially for those, again, very valuable algorithms that Dr. Goyal so elegantly laid out. Dr. Sigal, thank you for moderating. Thank you both for your continued dedication to both the AHA and, of course, patient and population health. Everyone, once you leave today's webinar, you'll get an email with a short survey. We would very much appreciate your feedback on that. And then there will be a follow-up email within 24 hours with a link to the recording of today's webinar. On behalf of the AHA and our wonderful presenters, thank you so much for joining us today. Have a wonderful afternoon.